Everybody can see? All right. So first of all, this is going to be a huge challenge for everybody because Kim has told me that I need to stay in this spot. Which for many of you, like me, is very difficult. So I purposely not going to use a clicker so that I have to stick here. So that'll help meet Kim's goal of having the speaker stay in the center. But in that, I've been in EMS for 46 years. I started EMS as Jim was starting kindergarten. I've worked at virtually every type of EMS system that you can. I started as a volunteer firefighter, volunteer EMT, then worked for certain emergency providers, public providers, county EMS director, assistant EMS director, and for the last 16 years have been with the public utility model forward. And started going through some transitions right now in the fire department. And as probably what happened with many of you or people that on seeing that tapped me on the shoulder and said, so what do you really want to do for the rest of your life? One of those people was Steve Worth and Doug Wilbur, who I have all the respect in the world for, and they convinced me, along with several other folks, to join their firm in their consulting practice called PWWAG. So I am now a consultant with PWWAG. Still work part-time, but I started in EMT, which is fun. And now volunteering for the fire department. So it's come full circle. I'm having a good time. One of the cool things is that as a public provider, this start was pretty young, and we did a lot of different things related to generating revenue for our services. And now working with PWWAG, doing a lot of work with agencies across the country on economic models and cost strategy, reimbursement strategy, healthcare, all sorts of things. So I'm going to try and amass some of that information for you here this morning. Because it's an intimate group, we'll keep it pretty loose. So if you have questions as we go, please just ask or anything, whatever, call them out. And we'll try to answer as we go. So assuming that all the technology works okay, we're going to do. Yeah, okay. All right, stand by, y'all. All right, here we go. You're working now? They're going down the street. All right, very good. This is the moment challenging I followed in different today. So understand how we continue to evolve. People here in the room are doing something in their systems today that they weren't doing 5 years ago. Yeah, almost half the room. How about work? What drove a lot of that? Okay, so the pandemic helped with innovation, right? Say, what else? Leadership. Leadership change. What else?
Technology.
Yeah. Oh my gosh, it's like we had a big meeting yesterday with folks about AI generated narrative and the pros and cons of AI for ChatGPT and those narratives by proof and see it. And technology changed everything. What else? What are some other
changes in community need?
Yeah, evolving community need. And I would say, in addition to that, changing community expectation. Right, and again, the pandemic's a lot to do with it. So we're going to see how some agencies have done a lot of that. One of the fun things we're going to do is something here. I have now 2 grandchildren. How many grandparents in the room? Yeah. For those of you that aren't grandparents, hang on. Because grandparenting is totally different than parenting. And it is way totally different. Because you can learn from up and send it back. And the relationship that you get between you and your grandkids are pretty amazing. So I have a granddaughter who's got a grandson now, and our kids live 1,100 steps from us. It's fun, so we get to have a good relationship. But there are times when, for whatever ill reason, they decide to have parental babysit. And I share with you some experiences that I've learned not to do. As that happens, and really what I meant, she never be allowed to babysit. So here's the first example. Making sure that the refrigerator door is inaccessible to the kid and that they don't perhaps get in trouble and all that thing. Now, I will say none of these pictures are from situations that happen with grandchildren. Okay. So the thing about healthcare system in general is that slowly our healthcare system is moving, trying to move from a system based on volume to a system based on value. The Affordable Care Act helped with that quite a bit. However, things like shared savings programs, accountable care organizations, managed care organizations to a large extent, everybody's trying to figure out how do we go from a press the button, get a peanut type of EMS type of healthcare system, which is what we're in today, to something different. The example that I can give you is you have payers that might not actually be an insurance company, that could actually be a group of physicians, that could be a group of different folks who are in a unique payer where payer pays less for the healthcare services and the providers get a percentage of that savings. That drives a lot of changes in how services delivered. We're like when I say slowly getting there, most hospital systems, most physicians are still reimbursed on a volume basis. As we move, Congress to try and move treatment and placement where we get reimbursed from not bringing people to the hospital. The one association so far that has been a little bit opposed to that legislative initiative is the American Hospital Association. And why do you suppose that is? Increase the volume.
Yeah, they need a peanut.
So we have to really figure out though, how we prove value to the people that are writing a check, because that is who determines this value. In communities, it's taxpayer, if you're tax funded. If you're not tax funded, it's your district folks that vote for a levy, or if you become an essential service, it's getting your community to agree that you are essential, and in fact, they want to pay you. A lot of systems around the country are facing that challenge right now. Iowa, it was the most recent, where they passed state legislation that allows counties to designate EMS as an essential service. And that makes everybody happy at EMS, right? Because hey, now we're gonna have to be providing. But the kicker is that the state legislation allows the county not only to determine by vote if EMS is going to be an essential service in their community, but how much they're going to be funded. Because there's no mandate in state legislation that requires funding. So the local community needs to determine that. So, but you also need to figure out who are the people that are paying you for your service. So if you are billing for the services that you provide, you've got patients that are stakeholders, you've got commercial insurers who are stakeholders, you've got state Medicaid. I know that Tim and a bunch of folks have done a lot of work with state Medicaid, but they are all stakeholders. They write checks to you, and they are the ones that will determine your balance. No one else. So it's important to keep that in mind. And we struggle with this whole in EMS, right? I mean, we have spent so much time, energy, and effort doing things to people. You know, a big battle over intubation and all these different procedures that we're going to do. In some cases, we've lost sight of the fact that our real goal is to do things for people. And doing the right thing for people might not be terribly intuitive based on having a litany of protocols so that when you have a cardiac arrest, through all the things that you need to do. Sometimes having the ability to prove value has nothing to do with clinical care that we're providing, but perhaps it's in things like preventing and having one problem. So, this is where we were. I think you're told my screen about it. All right, so let's see if we can do this well. So, in terms of proving our value, this was a series of studies. All right, who's moving the screen? Oh, you know what? That's it's me.
Oh, it's a good theory.
Good, yeah. Yeah, without worrying. New time. Now I'm fine. So open the door. Even the only hour it's been on the show in the video. Okay, so there's certain studies that have been done, a couple of them here in Colorado, that really call into question the concept of, response times, even ALS. Was anybody on the webinar yesterday? It was with the ICMN. The webinar yesterday with the ICMN called Mythbusters, and it actually had, several physicians, Dr. Kupis, Dr. Mackey, representatives from, public policy agencies, etc. And usually, of course, then people in the end, answer the question, like, do you really need an A or 10 response time? Evidence doesn't show that. The majority of calls. Do you really need permanent in the call? Evidence doesn't show that. No, it shouldn't, but to the call. So these are a lot of the research that's being published that have been published for years. That we are now finally, because of the things like the pandemic and things that have caused our systems to change. Little things like staffing crises and non-crises have led communities and really systems to look more at these outcome-based evidence research to say, yeah, you know, we probably are okay doing things differently. So here are some of the studies. By the way, you're going to get at the last screen, there will be a QR code that you guys will be able to scan from your seat. That will generate an email for you. And just click send, it'll send me an email, and I will send you a PDF of all the slides. All how this work, all that kind of stuff. So don't worry about taking notes. I saw a couple people taking pictures of the screen already, so don't worry about that. Just gonna get going in that. Okay. So again, big study on EMS response times. What they found is that the response times, if you're going to have a response time greater than 5 minutes, then response time really doesn't matter. And that having a response in terms of patient outcomes. If you're going to have a response time or the calls that need a response time of 5 minutes or less are about 1% of your call log. And what kind of calls are those? Call, cardiac arrest, not breathing, respiratory arrest, you know, that kind of thing. So really, if I were to ask the room, don't raise your hand, is your EMS system designed to get someone to the patient's side within 5 minutes of the time they place the 911? But every study that's been done on response times have shown that that's the only response time we manage. Well, why are we not doing it? Because the time that a secondary responder gets there, the time a paramedic gets there, would be within the hour, 30 minutes. But having hands on the chest, having Heimlich maneuver, having fibrillation at someone's side within 5 minutes of their call to 911. Not 5 minutes from the time you're notified, 5 minutes from the time they call 911. Doubles their survival. Where's the focus on that? They get people who say, oh, we need ambulance and they need involvement. You don't. It's remote. So this is what the studies have shown. So again, you can look through these, you have hot links, but basically here again, evidence-based, peer-reviewed, published data that says if you're not going to get there in 5 minutes, it really doesn't matter when you get there. And again, the call line that needs that 5-minute call line is about 1% of the call. I think everybody in the room would probably recognize that. We've also seen studies done on how people get to the hospital. So this is a study that was done in Pennsylvania where they analyzed patients that were trauma victims going to the hospital by police car or going by ambulance, and which of the two modes of transport do you think had the higher survival rate? Police car. Back in the early 80s, there was a study done in New York City on modes of transport to the hospital for blood trauma. And I looked at 4 modes of transport: taxi cab, police car, BLS ambulance, ALS ambulance. Of those 4 modes of transport to the hospital for blood trauma, which mode do you suppose had the highest survival rate? Taxi cab. Which had the least survival rate, lowest survival. Paramedic. That study led to a course that is done by an EMT called Fluid. Because after that study, a bunch of smart EMS people realized that we need to deprogram paramedics. And stop them from pumping so much Ringer's lactate, which is what it was in Mark, so the patient leaves pain. But it doesn't carry on. And they were screwing around on scene for too long, they bleeding out. Say weeks after that. And teach them to be 10 minutes on scene, plug holes, and move. So that was the genesis of the HTLS. Same study was done for penetrating trauma, published in JAMA by a private vehicle. So penetrating trauma victims that went to the hospital by a private car had a higher survival rate than those that went by EMS. And the only reason that we highlight these, and we haven't been in the handout, is because this is the value proposition, right? We tell people, hey, you need to have an EMS, you need to call 911, you need to have ALS. But yet, a lot of these studies, actually all studies that I know of that have been done about modes of transport to the hospital, ALS, VLS, etc., show that one of the worst things you can do is wait trains. It's kind of hospital. Cardiac arrest victims. This is one of the more recent studies. And this was a little bit groundbreaking. This was done by Harvard and a great researcher at Harvard who analyzed Medicare claims data and looked at Medicare claims data for cardiac arrest victims and looked at survival rates based on whether or not that victim received ALS care in the field or BLS care in the field. Which of the two cohorts do you think had a better survival rate, the ALS cohort or the BLS cohort?
BLS.
Yeah, so we've kind of showed our hand, right? So, and by a lot. ALS survival rate, CPC scores, walkie-talkies, as we say, 9%. BLS survival rate, 13%. So one of the problems with studies like that is that they end up summarized on the front page of the Washington Post. And what's the problem with having an article like this in the front page of the Washington? Who reads the Washington Post? I mean, they don't physically read it in hand, it's all the things that understand. Like they're fishing, policy. So back in 2016, when this came out, we got a lot of questions from CMS and from other healthcare, from other elected officials. We said, listen, we're paying you more for ALS transport than we are for BLS transport. Wow. Oh, paramedics more expensive. Why did you have to? Because according to the study published in Jared, it doesn't make power to it. You don't want to. What do you think? So why? And those are tough questions that the answer, the easy balance. But the tough answer is we need to figure out what is our true value prop. This is a series of articles that's done by the New York Times because they were lots of EMS care. This this study was done back in 2014, 2013 data. 17% of the total ER population is survived by EMS. Right, and that may be true in your system. Think about it. Of that 17% that we bring in, 39% of the patients are admitted to that. What's the flip side of that issue? 61%. So 61% of the patients that we bring in by ERs don't get it. They're what we refer to as treated and treated. How many patients in the room have brought a patient to the waiting room? Yeah. In our system, 27% of the patients that we bring to our level 1 trauma center, we bring directly to the waiting room. And we leave them in the waiting room. And they have a PIT program, provider and triage, where an NP or a physician sees the patient in the emergency room, treats them, discharges them from the waiting room. They never go into the door. 27%. So a great study yesterday that came out that analyzed the number of parents who call 911 appropriately when their kids are sick, and a lot. Or actually not yet, but the study is encouraging parents to make sure that they're calling 911 because the kids are seen faster. That was the analysis. So kids brought by ambulance were on average seen 2 minutes faster than walk-ins to the pediatric hospital's emergency department. And good news, bad news scenario. Good news is Maybe more parents will call 911 when the kids, fall down the stairs. Bad news, more parents are gonna call 911 when the kid has a sliver in his finger. Because now the study has shown they'll be seen faster if they're been by ambulance, which could be a good result. But figuring out to do it to 61%, is really, we're not bringing those people to the ER, we're not rewarding them by giving them a TDAP when they press 3 buttons on the telephone. We can bring a lot more value to the healthcare. Write the checks. And we do. All right, another reason I mentioned babysit. Yeah, how many people got the kids do this? Right. Again. Not a grandpa thing. This is not much to watch. So our economic model historically has been pretty easy, right? We call, we haul, that's all. Is that working real well for us? Economically? What are some of the challenges with that? People don't pay.
We don't need it.
Don't pay. What?
We don't need it.
Some do, but most don't, right? So they certainly don't want to pay for it. Because once they realize that they didn't need it, because they, thought they needed it when they called. Things like balanced billing, Medicare rates and Medicaid rates, and all those things that make it real challenging to live on a totally fee for service basis. We need to figure out in that value proposition how to live, and some of you are, or doing more than just schlepping people to the emergency department. So we've seen some really good efforts to see that. Some of you may have seen this in the past, but we've said in the past, I've said in the past, that EMS is a misnomer. Right, it does not represent what we do. Really, very few of what we actually do is emergency care, right? It's unscheduled. So if we think about really mobile integrated healthcare organizations, which all of you are in, and I'm doing paramedicine, paramedicine is only one part of mobile integrated healthcare traditionally owns. It's part of mobile integrated health. At MedStar, we changed our name to MedStar Mobile Healthcare back in 2014 to acknowledge the fact that 10% of our calls are emergencies, the rest aren't. But every call we go on, you're delivering healthcare. I don't care in a mobile environment. So that's a much more accurate way to depict what it is that we do. We do mobile healthcare. So since you pass mobile healthcare, that's your goal. 12 months from now, we're at the seminar. Right?
Right.
Good. Then mark it down. All right. Cost drivers for EMS. Our biggest cost driver is response time. Why? Yeah, cost of readiness. Right? If your community has an expectation of same day service, as opposed to a 10-minute response time, you can stack it. So we often say that, the shorter the response time, the more costly. That's true. That's the more time that you have to have people sitting around getting paid, not doing a call, in order to be able to meet a 10-minute, 12-minute, whatever response. I mean, ALS and BLS is a bit of a cost driver, not necessarily because of the wage difference, but because of the overtime. Because if you have to have a paramedic in the truck, you've got to hire back paramedics, keep them on overtime, mandate overtime, give them incentives to come to work, as opposed to a tier system where EMTs are just they want to work. And you can hire a bunch of them and they're on straight time, those sorts of things. How that works. And then your deployment model is your call volume in your community consistent over a 24-hour period? You have the same number of calls between where they do into the community. And in most systems that's true, you don't have that. So if you have more calls at a certain period of time than you do another period of time, why are you staffing? If you're staffing the same out of convenience of your workforce, that's wrong. You should be meeting the needs of your community. That's what somebody said earlier. That's our primary mission, to meet the needs of our community. If you're staffing the same 24 hours a day, but the call volume fluctuates, and by the way, predictably fluctuates. You're either being wasteful of the taxpayers' money during some times, or you're running out of resources during other times. Why would you do that? Just like your mission. The mission is to take care of the community. I'll come off my soapbox. we are beginning to see that there are states that are addressing some of this cost of readiness and also the economic challenge in the community by doing some, I would call them easy fixes, but you guys probably wouldn't, because locally it's really hard to do. So in some states, the Medicaid rate is very, very low in terms of reimbursement. Medicare rate generally tends to be a little bit better, but also is too low. But a lot of states now are taking the approach that we're going to raise the Medicaid rate to at least match the Medicare rates. So in a lot of states, that has helped quite a bit. In the example of Michigan, they passed a law that would raise this, they did in 2023, 2022, they fixed it in 2023. Do you guys have that here? Medicaid rate, parity of Medicare?
That's an 80%.
80% of
Medicare.
Medicare. Okay. And has it changed with the change in the Medicare fee schedule?
Actually, it has not.
Why not?
So
Oh,
the
yeah,
interesting
okay.
thing was, is when we got the 80% of Medicare, it was for that year, right? And so it wasn't legislatively done, it was administratively done. And so that rate that was paid is what it still is. So I think at the last Medicaid provider rate review committee, we found out that now it's right around 60% of what.
Yeah. Because Medicare rate inches up
Yep.
every year. Now, words matter. So one of the things that they found in Michigan was that when they passed the legislation that said, hey, we're gonna do the same rate as Medicare, you should use the term national fee schedule. Well, the national fee schedule is way lower than it might be in your community. Because of things like gypsies and practice indices and things. So the national average fee schedule, just so you all know, for now until January, is $272 for an ALS emergency call. Now, most regions don't reverse that because they have an index for local costs of equipment service and inflation factors and some other things. So in a lot of communities, the average Medicare reimbursement is like $550. Okay, but nationally, the average is 272, whatever I said. So in Michigan, they use the 272 instead of using the local Michigan rate, it's like 520. And the state said, no, that's what it says. It says the national fee schedule. So we're going to use, so they go back and fix it and say the localized national fee schedule, because they actually got a rate decrease Medicaid a little bit today, which is why they only figured out that they didn't impose it. Maine did the same thing, so the number of states that have done that. One of the greatest things that's happened this year regarding billing and reimbursement was the Ground Ambulance Patient Billing Advisory Committee releasing their report. Has anybody read the report?
Not covered.
So assume that most of you had not. Let me give you a quick highlight, because this really ties closely to increased revenue for you guys. And it's something that you hear from Asbel later today. Asbel led this, he was the chair of this committee, did an amazing job. There were some great EMS leaders on this committee, but also a lot of detractors. There were folks from the public advocacy agency, there were folks from the health insurance industry and Medicare, Medicaid. The report is 152 pages. There are 12, depending on how you want to count it, 12 or 14. Technically, there's 12, but some will 14. And then a bunch of other subcommittee findings. One of the things that we're going to mention in this room or online, but you are not allowed to mention it outside of this room. Very important. I have everybody's pledge that you're not going to mention it. No, you swear? Can't really do a pinky swear online. One of the most important recommendations from that committee was a revised definition of the prudent layperson standard. Because the prudent layperson standard has been used for 50 years, that's been a little bit dicey. So this is one of the primary recommendations. Here's why it's important that we talk about words matter. So the prudent layperson standard, as recommended by the GATFAC, is ground ambulance emergency medical service. Prudent person standard means ground ambulance medical or transport service that's furnished to an individual. What's the key word for? The committee did that by design. What does that set up? Remember, right, actions, what's open, but without using the initials. Because if you set the definition, that someone called an ambulance, the ambulance went. Court service, they provide enough. Assuming there's a patient, they provide enough care. Whether or not they transport it. It's a little bit wrong. The service there. That whole one. That one the key. So kudos to them for that. We've seen the public advocacy group, when the report was released to Congress, they did publish their statement, and actually it's not a bad statement. They, told that they continue to advocate for, patients not getting balanced bills, that they recognize the value of EMS, and essentially that they're okay with the recommendations. So when you have the biggest sort of detractor that would block some of these things going into place, as sort of saying it's okay, that's good. One of the key things in that balanced billing legislation or recommendation is that a state law that has been implemented and acted in a state for balanced billing, patient protection term, should apply federal ERISA mandates. The great challenge with state level patient protection legislation is that the legislation only applies to health plans regulated by the state. They don't apply to health plans that are regulated federally under ERISA. And ERISA health plans, commercial insurance represents about 86% of all health insurance in the country. So the number of health plans regulated by the state of Colorado, very small. Typically includes Medicaid, managed Medicaid, maybe some commercial insurers who are covered by state statute. So we love it when people say, hey, we're all excited, we got balanced billing legislation passed and the insurers have to pay us full charges. That's great, but it's only about 16% of payers the commercial insurance world. So just be aware of that. And to be honest, we did it in Texas 2 years ago. It is a bear to administer, because trying to figure out whether or not the patient is insured by a state regulated plan or by a federally regulated plan is an effort to just, because the insurance company is going to tell you right out of the box, no, we're a federal plan. Yeah. So we don't have to comply with your state balance billing agreement. But you were the state regulated. Which is often done these. But
Hey, Matt,
sure.
so one of the questions I've been hearing is, as far as the state regulations, once whatever policies are adopted by Congress, do you have to have the state plan in place before Congress adopts, or can you still modify your state plan after Congress adopts, and the state plan will still be kind of the gold standard?
So that's a great question, Tim. What the recommendation is that to the extent that states have passed patient protection legislation, the ERISA plans need to follow that state law. So if you haven't already, great. If you haven't done it, do it quickly. If it happens after, then ask them to swap it. Okay?
So okay, keep talking.
To the extent that it happens afterwards, that's fine.
Okay.
But they'll have to become compliant with the state law. Makes sense?
Uh-huh.
And it's not a herd immunity term plan. It's not really following. It's not like a state plan member or anything like that. But okay, this is just a state law. It says here's our patient protection law. I think one of the recommendations specifically says that to the extent that there are those state laws, then the rest of just have to follow that. And it's much easier, by the way, to get state law passed in many cases than it is. So definitely a good recommendation here. So we did this in Texas. Texas EMS Alliance, Texas Ambulance Association, a bunch of folks got together and really worked hard on patient protection legislation. And as we mentioned earlier, it's very difficult to implement to a large extent because you don't know the time of service and service time of payment if that plan, if it's had, was part of the state regulated health plan. Another good reason to mention that babysit. Right, this is a big deal over in the UK because they have a lot of, the break section about football over there and the real football, not football here in the United States. So another innovative funding strategy is find those revenue for new services. Go back to what we said earlier. Find out the value proposition for people writing checks. We used to have a great conversation. We used to go with folks from Eagle County paramedics and past and a bunch of others. That find out the payers that are writing checks for your ambulance service, the greatest amount. Go talk to them and say, is there something that we can do for you that give you more value than just taking everybody to the hospital? And you'll have data to support this. We talked about data this morning. But if you can show them the amount of money they're spending on you, the amount of money that they're spending on the emergency department visit, where 61% generally are treated and treated according to the ASAP study. Ask them, have that conversation. Sometimes it's not easy to find the right person to talk to in some of those payer groups, but working with your billing staff, working with the billing agencies, have them usually have some contact and you can start clawing your way to the surface. One of the things that we have found in negotiating contracts like these, where we're going to pay you for underwritten healthcare, pay you for non-transport, is that the turnover in the payer communities is way worse than it is in the EMS community. So, many times it will hamper or delay your education because you sort of have to hit the reset button like every 6 months and start a conversation with this person. So, what we've tried to do in the past is as we have conversations with network managers, network directors, ask them to bring in 1 or 2 of their team members. And so that as people turn over, you don't have to run this. We did a capitated care model across the field. Literally took us 18 months to get that done. And the person that we started the conversation with, there were 3 people in his position by the time we got the job. And part of the delay was just not the turn. So these are actual examples, and we're seeing them head up and get them, of agreements that we and others have got with payers. When I say payers, I don't necessarily mean just commercial insurance. I mean hospitals, health systems, ACOs, you name it, hospice agencies, home health agencies, who are paying us to do things that are not related to those transport. I think everybody knows about the ET3 model. What I will share with you is that the ET3 model was very successful. The goal of ET3 was to reduce one of the things that is that the average Medicare per ET3 intervention across all of the EMC after the patient EMS, after the patient call out, the screen practitioner, whatever, was $550 per intervention. EMS responds to 41 million calls a year in this country, probably 40% conservatively Medicare. Imagine if you could reduce that transport rate, that's relation. It's a pretty significant savings. So being able to then take some of the lessons learned from ET3 and go to your local state and figure out, is Medicaid willing to pay for treatment of cancer? Is your patient protection law that you're going to propose include treatment in place? There are a handful of states that have passed state law require insurance carrier pay for treatment in place. But if you're not currently going for treatment in place, work with you talk to your folks, that director, your whatever, it's probably not a bad idea to start with. You've expended time, energy, and effort to get an ambulance to a call, 8 minutes, 10 minutes, 12 minutes, 30 minutes, whatever. And you're going to be on scene for 30, 40 minutes, doing whatever you're going to do. Should compensate you. And what we have found, at least in MedStar and some of the other systems that I've looked at, is there are some payers who will pay for treatment of. So there's no reason not to go. You could have a write-off policy that's contained, it's not paid, and we're not going to watch the patient when it's we found it also helps to control the system user. So if you get it $800 bill for treatment in place. Even to pay it, it's not the one that should do the same.
For everybody in the room, it sounds like Colorado Medicaid is 12 to 18 months away. We're hearing, remember that 12 to 18 months away from paying for treatment in place. And the biggest success we're seeing is in the motor vehicle, the casualty companies. The motor vehicles are paying dollar for dollar bill for treatment in place.
Yeah, because they're paying under liability part of the policy, not a healthcare part of the policy, and,
Right.
our figured out all the time that, especially with car wreck, they can bill for rescue service, the insurance company pay for that. They can bill for the health. The insurance companies pay the bill, that's fire. We need to figure out how to do that. Good news is that there's several pieces of legislation working their way through Congress, part of this new potential revenue stream for EMS that does reimburse us for treatment in place, transport to alternate destinations. And really, it's mostly treatment in place. Very rarely in any of the current legislation to talk about transport to alternate destinations. One of the lessons that the industry learned during ET3 is that there are not a lot of places who want to take our mission by any governments. So transport to alternate destinations really means you have alternate destination. In many cases, that's hard to come up with. Treatment in place is really the big win. The data from ET3 showed that 94% of the claims paid under the ET3 program was for treatment in place. 4% was for transport to alternate destinations. But yet, transport to alternate destination was the required service they had to provide. Treatment in place was the optional service. Well, as many of you have been in EMS for a long time, and having this level of legislative activity in Congress is a little bit unusual. Affects a lot of it. And the interesting thing about all these current pending legislation is that they all help us. Normally, we are up at Capitol Hill fighting bills that hurt us. But today, because of things that happen, because of things that you all have done, advocating for things like the profession, we're having very good discussion with members of Congress, with other constituency groups to move legislation. One of the great things that happened during the pandemic was the American Ambulance Association, NAEMC, IFC, IFF, and the EMSP, the leaders, the volunteer leaders, and the executive directors, lobbyists from local organizations started communicating with each other. And to this day, we still meet one Friday a month at noon, by noon, that's where everybody is in the country, and we coordinate on things that have made us effective. And that's one of the things that's led to so much legislation getting in this, and certainly being introduced in the last several years.
Yeah, what's the time frame on medical access ambulance?
Years.
Years?
The language hasn't even been drafted yet. So this was an NAEMC initiative. Long story short, got a phone call from Senator Tetzer's office in Montana. Hey, we just lost an EMS agency in one of our rural communities that the last country and see got that coverage. Possible. How did they knew what they did? So suggested that they talk to the critical access hospital about potentially providing that service. And a few months later, they did, and the critical access hospital picked up providing the service. But then the thought was, why? Because of the reimbursement model difference, why should that difference in reimbursement model be put to the only critical access hospitals? Why can't we get a critical access ambulance application that says if you're the only ambulance provider for 30 using the same criteria for the CAs, the only ambulance provider for 35 miles or whatever, and all the other criteria, that you get a different reimbursement model than regular ambulance agencies, sort of like you get the bump for super rural, but it becomes it switches to a cost-based reimbursement, not the fee schedule.
Just to let you know, we're working really closely with Representative Brittany Pedersen out of Colorado. She's very, and her staff is very interested in critical access ambulance designation. So it's very possible that if we can get a bill written. And if we can get it reimbursed for the first time, it'll be from a Colorado representative.
And in fact, it was from that meeting that the legislation or the draft firmly in being written, legislative one. Because of Colorado's and getting a Colorado representative really interested in this competitive with Democrat. The House Ways and Means Committee has actually taken a keen interest in a lot of the things that are happening in EMS right now. So Dr. Ed Rock and I, and obviously Dr. Rock and Mark had the opportunity to testify for 3 hours, by the way, at a field committee meeting for the House Ways and Means Committee held at AMR's aeromedical base in Denton, Texas. Also, with me members of the trees involved in that, which is very odd. But I just literally had a conversation this week with one of the lead staffers, because the bills for treatment in place, the other things that are happening, they have a keen interest in because of their economic impact on Medicare. So it's got now to the point with some of these committee staffers, is giving them examples, how does it work? And when we gave them, here's the bills that we sent to here, here's the reduction in utilization in their population, and we really asked the question right now, the staffers of the committee are, okay, do we need to make this a great program, or should it just be a computer knowledge being evaluated for 5 years? And he said, it shouldn't be last thing that we need, every grant program. You need sustainable revenue change. So those conversations do continue. Representative Smith was the chair of that Ways and Means, a huge advocate, EMS, and the chair of that committee. So we have put together some estimates of what that savings would be. So in the link, you'll see that you can download these documents. They're really important, and they'll be good for you to have when you go to talk to folks about changing your funding model. Here's the information that we got from CMS regarding the ET3 model savings. This is from them. So net savings to Medicare after all spending for that year. And you'll note that they categorize them into 4 different groups, but the average amongst that is $555 net savings to Medicare per intervention. So to say that the program is unsuccessful, there's not an unsuccessful program, it's unsuccessfully implemented. Program is very. This is why several states have begun to implement this. This is Tennessee, Michigan's done it, Maine has done it, Illinois just did it. In fact, Illinois just passed a lot of cases with community permits. In addition to treatment place, so it is happening around the country. But don't rely on the state. Just talk to your payers. We talked about it earlier. Here are examples. These are contracts that we're getting paid for treatment in place, and we're getting paid the same rate as if we had transported them to the hospital minus the mileage. So this is an example of the negotiation that we had with one of our commercial payers regarding this, and they said, "Hey, we'll pay you the $12.70 or $12 for the ALS transport, but we'd like to pay like $300 for the non-transport." And we said, "Well, why would we do that? We just transported them, right? If we do what we always do and convince them to go to the hospital or they're going to die from their splinter, then we get to get reimbursed $1,200. But if we don't bring them to the hospital and get reimbursed $300, then we're not going to do that. We can do the agreement, but you'll never see that code sent because we have no block." So they finally agreed. So they paid the same, a couple of commercial paying the same rate for the transport as the non-transport, just no mileage charge, obviously. They also, as of now, are paying for the CPC code for non-ambulance related services. So for example, if we send a community paramedic or community EMT, which is spot on a proactive home visit, with a scheduled home visit, we bill them, they pay. If we treat their transport, we bill it, they pay. If we send a paramedic in a flight car to a low acuity 911 call, because history has shown that the 26 alpha 2 to the 14% transport rate since the flight car only. Don't send ambulance by type of ambulance for call 14%. Then the patient is successfully treated on scene in that transporter. We didn't even send an ambulance. The building, the CPT code they take. Stop this down. What started this is the payer said, one payer started it. They said, hey, you've been on transport for about 6 months now on our 3-year agreement. It's working really well. We're getting a lot of no transport bills, which means that we're saving a boatload of money on the back end. What's next? What can we do next if we amend our agreements sooner than its renewal to do something more? So that's when we had a conversation about what if we don't send an ambulance? And this is a wild conversation. He said, well, they said, you know, if you're not sending an ambulance, then we can't pay the 3-9 the Hicks code, A11 for free transport to send an ambulance. That's an ambulance. I said, that's fine. Let's keep sending the ambulance. Let's be able to call it and then call it. We're willing to pay like 200, send a flight car all the way. But if you can't do it, that's okay. We'll just keep sending the ambulance. And on this, all the calls we talked about. So I got back to them and said, looks like, you know, with your population was about 9,000 calls a year. I said, well, what are you doing? They did it. And it's all about changing how they perceive your value. They'll pay for stuff that they think is valuable to them. That, and again, all this information is here. We talked about the essential service designation. This is something that, from again, an innovative funding model, do not be afraid to do it. Tim, I'm sorry for those, but is EMS an essential service in Colorado? Okay. Just use caution. Much like the Iowa, much like these other states that have done it. Because you make it an essential service designation doesn't mean it's going to be funded. It's up to the local community funding. In Iowa, when they did it, it was very bizarre. So, as I mentioned earlier, the states said, hey, counties, you can designate EMS essential service through a vote of your electeds. But only county with a population less than X can designate EMS an essential service. So the 5 largest counties in Iowa cannot designate EMS as because they're above the population, which is involved. Now back to the politics, they say, hey, those users do not want to fund the EMS. That's a pushback that you can get. Try doing this, try doing it in other states. The pushback comes from different counties, city, because they are very sensitive to tax rate changes and losing an election. So they would either, if the EMS becomes an essential service, they would have to fund it. But don't fear that. So many communities, when the community learns that EMS is not funded, they're having a real hard time providing service, and they're losing personnel, they're exiting systems. When the public is educated on whether or not they should fund EMS, overwhelmingly on these referendums, overwhelmingly they pass. And usually pass by a lot of money, or by a lot of percent. So you have to do a good community education campaign. You have to run it like a campaign. And to educate the public and let them realize that yes, it is an essential service that people didn't know wasn't an essential service. And that makes it sense to get. Of course, not. The community is passionate about it. You'll leave tomorrow. Nobody gets in trouble. Yeah. So we strongly recommend to do this. This is a news story from just this week, where a community in I can't remember where is going through this exact process. So they are running a campaign to pass a levy that would result in each household paying $157 a year for a typical $100,000 home. And that would bring in $6 million to that agency. And every person that they interviewed for the story said, I'm gonna go for it. That makes sense. $400 a year. Make sure I got an ambulance if the kid falls off the roof. Good. What's the issue? What? So what is this problem with? The National Conference of State Legislatures has a great database. You want to get it, you'll go to the link. They'll show you all of the state laws that have passed related to EMS. One of the things it will also show you are all the states that have done EMS as an essential service system. And the legislation that you use to do it. When you settle it, James and A, submit to a friendly state elected official and see if they're willing to introduce the law. Make it really simple. We'll hear of some of the adverse and beneficial services. That's what it was like, $50 that it. Mention that babysit. So I listened to Daytona Beach, broke my heart. Couldn't believe it. I lived there. Again, these are things that did not happen on Grandpa's watch. Things, yeah. All right, last thing I'll mention is this EMS on demand. So is, does Colorado allow you guys to do a subscription program? Membership program for?
Not technically, no,
Technically.
not technically, because they refer to it as an insurance plan and it has to be, actuarially sound within 10 years.
Okay,
Those are the general rules.
in many states, that's still the same. So you have your revenues have to match your expenses, and the amount of money they write off has to be similar. But several states allow this, it's not like you're limited. So what we did was we took that to the next level. We have subscribers, a bunch of them, that are part of our Star Saver program. That allows people to not be balance billed, essentially, for any bill. Because they prepay if you want to for the household. We heard that there were agencies in our community that were offering concierge medicine service on a subscription basis. Hey, pay us, X amount of dollars a year, and we'll have a doctor available to you come out to your house anytime, whatever. And they were getting paid a lot of money. People were signing up for these. We said, well, wait a minute. If someone's going to get paid to reduce our call volume, it should be us. Shouldn't be the ones doing that. So we rolled out an enhancement to our subscription program called Star Saver Plus, where the people get not only the full benefit of the regular subscription program, but they also get 24-hour access to a community paramedic on demand. 10-digit hotline, call the communication center, will send somebody out. They also get a response from the community paramedics when they call 911, because the CPs have a different protocol that they use. And oftentimes they treat that patient at home, not bring them to the ER. So they get that call response. $350 a year. People are signed up like crazy for their household. A normal subscription, by the way, program, $69. But we see a lot of people getting this for their grandparents. We see a lot of grandparents getting this for their grandkids. And it's, again, it's in a sense. This Colorado is EMT state.
Yeah. Yes.
All I'm gonna say about this, in order to wrap up, is whatever money that you're seeing coming from your GMT program, you are not gonna have that money to do. So everyone figure that out. It's up to you. Long story short, the obviously President General, has been auditing cost reports from VMP programs. Then found some interesting findings. And they believe that the majority of the cost reports across the country for the GEMC programs, specifically from the fire service, about wrong. Way wrong. Big wrong. And they're going to change the program, seems like, to not be a cost for readiness, cost for all those other things that are already built in, but a time stamp, the time that you're actually on transport for a Medicaid beneficiary. So from the moment that you touch your Medicaid beneficiary to the time you get into the hospital, it's the only cost they're going to reimburse under the GEMT. They've already sent that unofficially in writing. Some states that are waiting to get their GEMT programs approved and have asked for things to be included in GEMT process. And Medicaid has been federal Medicaid. They said, no, not paying the cost of readiness, that's not transport character. No, we're not paying for overhead. Because that's not part of the transport. No, only pay for the time. It stands here. Question is, for the time period that they're auditing, is Medicaid going to do what Medicare does? Want to, they believe that from favor of public. So we're all looking to do that. And you'll see in the handout, there's some of the emails and the identified, of course, that show where Medicare, Medicaid is heading. A number of us from NAEMT actually met with Medicaid back in May of this year. And they made it very clear that they're not backing off this. That new rules are going to come out. They think that we, as an industry, have taken liberties, specifically with the top one, that we're going to be taken. And they're going to direct overpayment back to states in the GDP program. So keep an eye on that here, states. It's probably going to change quite a bit. Final word, know your value proposition. It's not necessarily just being an Uber to the ER. Your value is much greater than that. You just need to be able to convince not only yourselves, but people write checks from the investor. Now this may or may not have happened under my watch, but all right, here's the QR code. So if you guys want to scan that from where you are, it should, if technology works appropriately, bring up your inherent email system on your smart device and literally just click send. And later today, I will reply with the PDF of this and send it all, including all topic studies and NCSL and all the stuff. And for people online, sorry, I keep forgetting, even though you name is staying in the spots. Just send an email to Kim.
I will be gathering all of the presentations and we'll have them available after the conference.
Okay, good. All right, thank you all. I think you guys get a good thing.
No, we're ready to move on, but you're just a little early, so that's perfect. Are there questions for me?
Thoughts, Matt, on the trickle down? So from the MedStar perspective, I mean, big agency influence with insurance companies, you can throw out numbers like, well, we did 9,000 with you. I'm sure in Texas, much like here, a lot of the agencies are small. So if some insurance company calls me, I tell them the number is 9 as opposed to 9,000. And yeah, I'm just curious if you have any thoughts or have any experiences. Were you able to trickle down any of these innovative practices to the smaller guys or share or regionalize any of this stuff?
That's a great question, Sean. And the answer is yes, both on a state policy perspective, but also, so when TAA and Tempest and others were moving to try and get treatment replace legislation in the state. Yes, they used a lot of data from large agencies for doing treatment replace programs, but those laws apply to every agency. So today in Texas, if you're in a licensed EMS agency, you transport a Medicaid patient, you don't transport a Medicaid patient, you bill them to pay. They're not transported. Same is true for some of the payer negotiations. So the couple payers that we did this in Fort Worth have already gone to San Antonio, already gone to Dallas, have already gone to the even smaller communities and say, hey, we have a fair number of members in your community. Would you be willing to do this? What I would suggest is what South Dakota is doing. South Dakota is making a really strong effort to have their state association be the one that's doing a lot of that data collection and a lot of that analytics, because it's a different decimal point in individual agencies and negotiating for the agencies in the state as the state association. So you can do that with regions here, you can do that in a statewide level. But if you need different decimal points, then find out who has those different decimal. One of our commercial payer wants to do an innovative payment model to mobile care healthcare, but they needed called Fort Worth in Dallas as the product because rectified we have this number in Dallas and Fort Worth. So we did an interlocal agreement with Dallas Top, the city of Dallas, and we became a single provider in the eyes of that payer because we share data, we share teams, we all that stuff. So collaborative partnerships really helps for us.
So going back to when you were talking about private insurance companies, like payers, and the agreement that you worked out for quick response vehicle versus ambulance, there's a huge disparity in that price set there. The value is the same to the insurance company. Why negotiate such a low rate If the value is the same for them, why shouldn't we share in that cost savings?
Part of that was we're a public agency, we're a little bit realistic in what our cost of providing services. But more importantly, one of them to do. Because to our knowledge, at least in our system, and not been done before, we wanted to give them enough financial incentive to turn on CPT code bill. Which is really what it came down. That was the bigger win than just the individual payment to flying car now. Flying car response is only in our system, it's about 14% for a full call. The cost difference is dramatic, not necessarily because the cost of the paramedic, the cost of the vehicle and all that stuff. It's the cost of readiness. It's different. Because if we send a flight car only to a call, we get there within the hour. So we don't need to have as many flight cars on the street as we do ambulances. So we negate that cost of that cost of readiness because we to some extent we schedule that. But still getting 175 bucks for a within the hour response for a single unit for that started that process. Now it won't stay at 175. But at least it got us to be able to bill CPT codes and got them to flip the switch to pay CPT codes. That was really the bigger win. By the way, you may have seen in that contract, we get reimbursed if we disposition the call. So to the extent that we're taking a call, the triage, we go through all the triage process and it's a low-level call. One of the questions that is asked in our call center is, who's your insurer? Now, I know that bristles a whole bunch of people, but if you've already determined that it's not a life-threatening emergency, it's not even urgent, it's gonna go to a nurse. We don't use nurses, we use paramedics or EMTs, but if it's gonna go to an alternate disposition, it's a very low cost. So asking at that point who the insurer is, then we have a zone. And if it's one of the two insurers that pay us for dispatch triage, say, great, let's connect you with a telehealth provider and send you a link to your smart device, click on it, and you start a video chat with the units of the and maybe we are going to be from the city, maybe it's for your life. Nobody works. Okay.
So it's interesting when you look at some of your data presentations, if people do better, have better outcomes coming in by taxi cabs, POV, and BLS ambulances, do we need as many paramedics as we've got? Or do we need them in different places?
Well, first of all, those studies, and they're peer-reviewed published studies, and they're reviewed, were for specific call types. Penetrating trauma, blood trauma, well, the one that sort of got a little bit sideways was the cardiac arrest. Because we collectively built EMS systems based on cardiac arrest column. That's why you need a paramedic in 4 minutes. Seems like we don't. So that's where those studies were from. The larger question of needing a paramedic in every call is happening in many communities across the country. Many. Because of the staffing shortage. Let me even say paramedic shortage. So communities, because they have the right now and the data and at least the conversations to ask those tough questions. What is the clinical value of having a paramedic in the call? And looking at your data, looking at your outcomes, most times we looked at it, 40% maybe of all TVR. So when we did it, 40%, and that's hard, 40% of our patients got ambulance care. 40% 911. Of that 40%, only 20% got a drug. Which means 80% got monitoring. What drug is most commonly used?
Children.
Okay. Usually during the ambulance. So you need a paramedic kind of call. And a lot of communities are being looked. When we went to a tiered system, we went from having the ability to staff 750 unit hours a day with 10-15% of those unit hours being staffed by overtime paramedics from overtime to time and a half or $800 one session. They had a problem. Today, staffing almost 1,000 unit hours a day on the street. 40% of them are BLS. And we're not stacking bodies like storage weights at all. So you need to ask yourself that question. Do we really need paramedic? Oh, no. Even that later.
So with that being said, maybe time, so. How do we get into the community EMT realm versus the community paramedic realms we're talking about? That because there is some benefits, I think, to that, as your tiered response, which. You obviously have a great dispatch system that works with you on that, we cannot.
Our dispatch system.
Yeah, so there's that, but how, I mean, how does that?
And I'll add on to that, there is no credentialing
work?
for the community EMT. Does that even matter? So you know you can get a credential for a community paramedic, but not the community EMT.
Who credentials your community paramedic?
So I guess it's through the whoever that outfits who is that does that, and then you get an endorsement from the state to be a community paramedic.
So that's a certification, right? That's a little different perhaps than you get. It's the IBSC issues a certification.
Right.
Credentials different. Typically, your local system, your medical director credentials your provider. Just because they've got a state card doesn't mean they can work in the system. You go through a credentialing process. So you credential EMTs in your system to be community EMT. What we have found over time is that like this much of the time that a community paramedic or EMT is with a patient, most of it's educational, social determinants of health, connection with other resources, getting them to like their doctor, getting them back to life. They'll let people. And very rarely do they need medical intervention. They need medical intervention that's beyond the scope of an EMC. Call paramedic, call you. And then wait.
And I think this is the perfect time to have this conversation because in the state of Colorado, the KISS agency licensing process is getting ready to sunset. And Dora put out their recommendations in kind of weak, but there is an opportunity now to seek new legislation to change some of the rules around that. And so if adding EMTs or community EMTs as part of that under KISS, that might be a great opportunity. So I think the answer is, unfortunately, kind of changing the legislation a little bit. Instead of just rubber stamping what we've been doing for the last 10 years, let's be purposeful and intentful with the knowledge that we have over the last 10 years to make meaningful change.
It would be important to look at the interventions that care provided in your patient cohort to mainly through DP programs. Because your cohort may be different. If you've got a lot of medical interventions and diuresis, breathing treatment, but if you find that there are interventions being provided by the C that truly require ALS assessment intervention, then this might not be an option. But if we find that majority of this education is, again, helping them with their diet, helping them with meditation compliance, helping them with motivational interviewing to want to change their behaviors to stop going to the ER, that's EMT or less to the health worker level. I agree.